Hello, everybody. I don't think I'll try what Michael did because I don't think the kit would suit me really, certainly not the shoes. I'm really delighted to be here today because those of you, and many of you in the audience I've known for a very long time, will know that like Michael, my two main passions have been to ensure that clinical leadership is much more at the forefront of the NHS, that clinicians take their rightful place because of their close relationship with patients in helping to drive the changes that we all want to see for the population. And secondly, that general practice, because of its core and central role, should also be much more at the heart of driving change for patients. So I think, as Michael's absolutely rightly pointed out, today we kind of stand on the cusp of, there are a few more months to go, but we stand on the cusp of a monumental change as from April the 1st, 2013. Much change is already underway, but April the 1st, 2013 is the absolute date when we move from this transitional period we're in at the moment to the complete new system that has been designed in a way, and if I can remind you all, the three central tenets of the reforms were firstly that we would put patients and the public at the heart of everything we wanted to do and give them much more power and control either of their individual treatments as individual patients or as of the design and the way services were delivered as public and communities. That we would put clinicians, particularly primary care clinicians, with clinicians much more in the driving seat of the way that we delivered that change.
Where is it?
And that we would base much more of what we did on sound clinical evidence. And if those three reforms, those three tenets, are actually central to everything of the reform changes and the commitment this government has had and has stayed absolutely true and firm to those commitments and remains, I'm sure, firm to those commitments, as Chris pointed out, despite our change in ministerial team. I mean, you'll hear from the new Secretary of State tomorrow, but I'm sure many of you have heard him say his absolute commitment to the principles of these reforms. So just a little quick canter through, you know, all the players on the pitch, and then I will come to CCGs, but I want to talk about CCGs, and I particularly want to talk about the central role of primary care.
The man who knows everything.
But if I can start with the NHS Commissioning Board, not because I think it's the most important, CCGs have the bulk of the money to spend, but I want to to go through the other players and then talk about CCGs and then seamlessly into primary care, I hope. The NHS Commissioning Board is a non-departmental body. It is very different from anything that we've had before in terms of running the health service. And I do not think anyone should underestimate the power of the mandate. If you look at the back of the mandate, as well as a set of outcomes that need to be delivered for the population, what that mandate does is it gives the NHS Commissioning Board, I won't get the number right, it's something like 95,653,000,000, but it's a huge sum of money in order to run health services in England. And that is a very significant change from the way we've ever done things before. It is absolutely determined and was enshrined in the Act to remove the day-to-day management of the NHS and the oversight of the NHS, the leadership of the NHS, from the Department of Health and the government to this non-departmental body. Now, there are other very significant bodies on the pitch: Monitor, the NHS Trust Development Agency, Public Health England, Health Education England. But the NHS Commissioning Board in it has a very significant leadership role in order not only to oversee CCGs, but to make sure that the whole system works in a coordinated and integrated way in order to integrate services for patients in the way that Michael was talking about. The board is absolutely committed to clinical leadership. There are three of us are directors on the board, one of whom many years as a frontline nurse, one of whom was many years as a secondary care clinician, and me many years as a GP. Between the three of us, we've got decades of actually being frontline clinicians on a day-to-day basis on the board of the board. It's a bit strange, the board of the board, but the board of the board has three long-serving clinicians. If you hear the Chief Executive, David Nicholson, or Malcolm Brown, the Chairman of the board, speak, you will hear them time and time again reiterate their commitment to clinical leadership and to supporting and nurturing CCGs to be the best they can be. I know David isn't able to be here over this for this event. Most of you all know that David's expecting a new baby in the next few days. I think is the due date. But you know, if he was here, I know, and I know Ian Dalton's coming down tomorrow, and he will say this as well, that he would want absolutely to reiterate his commitment to supporting CCGs, to getting away from the old top-down, telling people what to do. We all absolutely and passionately and firmly believe that, that if we can liberate frontline staff, if CCGs can be the light on their feet, clinically led organisations who can really engage with patients and the public and their other stakeholder partners to drive change 211 different ways, albeit in part of one coordinated whole, that's the way that we'll get the real transformational change that our population needs in this time of rising need and such economic difficulty. So our commitment to support CCGs is absolute. I do hope that through the authorisation process you feel, and the feedback we're getting is already that the authorisation process is helpful to people. Looking back at my time as a PCT chief executive, I was one of the early PCTs, and actually I think they stopped the process, so not every PCT went through it, to go through a comprehensive CHI healthcare well, there's child healthcare, I can't remember, but a comprehensive inspection and review, which is in some ways a bit similar to authorisation. And like you, I remember going, oh no, all the work, everything we had to do. But believe me, we came out of that as a much better organisation. It ordered our thoughts, it helped us to understand everything we were doing, it helped us by actually describing what we were doing, how we were involving patients, what our governance looks like. It helped to make it much better. And I'm absolutely delighted to hear that those who have been through authorisation are telling me that that's the same. That I had some concerns, and partly because I've travelled the journey. You know, I've gone in a very short space of time from being a GP one day and the accountable officer for a very significant organisation a few days later. So I know what it's like, and one of my worries, and I'm sorry if this offends any of you, was I was worried that there would be some instances where people didn't know what they didn't know. Because, you know, believe me, when I started, I didn't know what I didn't know, and a lot of people helped me. But I'm really pleased that people say to me, you know what, Barbara, the authorisation process has helped us to understand what we didn't know. That's absolutely great. John Buick is here for the 2 days with you. He's one of my senior directors in the NHS Commissioning Board. He's been responsible for overseeing the whole of the authorisation process. And John is then, once authorisation is finished, is going to be he's got the substantive post of being the director responsible for all CCG development. So I'm sure he'll want to pick up lots of things from all of you today to say, when we move from authorisation into longer term support and development, what would that look like and how can it help you? So if we just think about, okay, so if I was a CCG, what would I now be doing? CCG is doing well in authorisation. The early indications are that many will be authorised without conditions. I think some of the earlier waves will have some conditions that they'll be able to remove by April the 1st, 2013. They're conditions that they're just there because of the majesty of time. I don't count those as real conditions. We're optimistic that very significant numbers by April the 1st, 2013 will have no conditions at all, that another very significant number will have very limited conditions which are about supporting them because the CCGs can see themselves the need for development. A few, I think, will need some more significant conditions, but we hope the numbers are very small. So if I was running as a CCG now, what would be the key things that I would be thinking of, which hopefully the authorisation process would have given me a way forward on? Well, firstly, I would be thinking, how can I be really different? And being really different has to start with patients and the public. And we have never, as a health service, got it right. We've tried. I don't think that people haven't been committed, but we've really never got to the situation where patients are much more able to be empowered about and in control of managing their own disorders. We've never really got to the stage where we reach out to all the communities and understand what it is they want from their health services. And I have got really high hopes, really high expectations of CCGs that they can do this, and because of their basis and their foundation on the practices, and because of their relationship with their local communities that gives them. So that would be my number one thing, but there would be a lot of other groups as a CCG leader that I would be wanting to concentrate my time and effort on making sure that I had the right relationships with them. After patients and the public, well, in no particular order for these things, because an order would be unfair. But actually, one of my key thoughts would be, how do I keep my practices on board? How do, we have designed this policy in a way that absolutely puts practices at the heart of it. Never before have we had membership organisations. Other organisations have kind of been built from the top down. These are built from the bottom up, and the practices are key. And when I say practices, I don't just mean GPs. I mean, all those who work in the practices need to own and belong and feel that the CCG is theirs. If a CCG ever says, actually, or if the practices over here are doing this, or if the practices ever say that CCG over there, you've lost it. You might as well go back to being a PCT, who did some great things, by the way. But if you wanted to make that step further to make it really different, the CCGs and the practices must be one. Now, that's lots of work with the GPs, because in general they're the ones who are the owners of and the contract holders for the practices. But it's absolutely key that practice nurses, attached community staff and practice managers are intimately involved in the business of the CCG. When I ran a PCT, when I was a chief executive of a PCT, we had a practice managers meeting to which all the practice managers attended. I know some CCGs are a bit big, it might be more difficult, but every single month. And as the chief executive of the PCT, unless I was on holiday, I always went to that meeting. And I hope, I don't know if any of them are in the room, that all my practice managers at that stage felt they could pick the phone up to me and say, Barbara, we're worried about this, we think this is not happening. So again, for those of you in CCG leaders, think about the practice as a whole entity and never underestimate the power of the practice managers in helping you to help the practices be the best they can with you. The local authority and the health and wellbeing boards, absolutely critical and key. I mean, not only are the local authorities your partners in terms of commissioning, because they have quite a big commissioning responsibility, some of which of their commissioning responsibility could even well be from primary care contractors. But the local authority has the responsibility to create the local health and wellbeing board, where all the partners, the CCGs included, a CCG is a member of a local health and wellbeing board. It's not about the local health and wellbeing board holding the CCGs to account. It's about all the partners in the local health and wellbeing board holding each other to account for creating the right strategy and then all playing their part to make things better for patients. So that relationship with that health and wellbeing board, with the local authority on the integration of health and social care and the broader determinants of health will be absolutely central. Your relationship with your providers is absolutely key. The worry about these reforms, right though I think it is to put general practice who coordinate care for patients as the coordinators of commissioning. The worry is always that other clinicians feel left out, other organisations, other people who support clinicians in other organisations. And it's CCG's responsibility to make sure that doesn't happen, because we won't get integration, we won't get the right services, we won't get the best clinical and managerial brains together unless it's those who come from providers as well as commissioners. Good commissioners, what they do is they bring all the people round the table who have a relevant interest or experience in order to design the best services, and then on the basis of that they work out how to secure or contract for those services and monitor that what they've said is being delivered has been delivered. And in that planning of services, if you do not have, as well as patients and the public, the key experts, the specialists, the teams of people who deliver those services in secondary care or in community services or in social care with you, you cannot possibly plan in the way that is best for patients. Your relationship with NHS Commissioning Board will be absolutely key because they're commissioning primary care. and their commissioning specialist services. So that partnership arrangement between the commissioning board and the CCGs, the commissioners, the dominant commissioners of NHS services, if that isn't right, then we are going to see fragmentation and we're going to see problems for patients that we don't otherwise want to see. So concentrating on that relationship will be absolutely vital. And of course, concentrating on the relationship with your partner CCGs, because no man is an island, most CCGs aren't an island. There will be the occasional CCG somewhere in the country that is lucky enough to be kind of coterminous with one local authority, to have one absolutely main secondary care provider with whom they do most of their business, and the same for mental health. And that CCG probably needs fewer, but not no relationships with other CCGs at all, but fewer. But for the majority of you, in order to design services best for the patients and work with your providers, then the sorts of relationships you have with other CCGs are critical. Again, we've, as part of the process, left this up to you. We haven't stipulated, like we did before, that you have to have lead commissioners and associate commissioners. We've said no, it's up to the CCGs how they decide to do this, because again, in the past I've seen instances where lead commissioners almost felt like the go-between. So one PCT acting as lead commissioner, they sorted lots of things out with the provider, and actually there was then an enormous piece of work to bring the other commissioners, the associate commissioners, alongside, and we don't want to see that. For your sake and for the sake of patients, we want to see really strong, robust collaborative arrangements across CCGs so that they can do commissioning where it needs to be done across a broader geography and with the NHSCB in a way that's properly governed and properly organised to make it as smooth and as slick as possible. But I think one of the things that, if I was as a CCG, what else would I be concentrating on as part of all the relationships? And what I want to move on to finally is primary care. And Michael talked about two sides of primary care, provider and commissioner, inextricably linked, two sides of a coin. And we need to work out how we make those two work together. So if you can just think for a few minutes particularly about the role of CCGs in commissioning primary care, not in commissioning primary care, in supporting the quality and commission of primary care. Because what is absolutely clear is that the board holds the contracts, the basic GMS, PMS or APMS contracts, for general medical services, and it holds all the contracts for dentistry, optometry and pharmacy as well. But CCGs have a duty of partnership and a duty to improve the quality of primary care. And there will be many, many things that CCGs do as part of their commissioning, which are actually about helping primary care, the totality of primary care, but perhaps in particular general practice, to do things in a very different way, which has a knock-on effect and an impact on commissioning of secondary care or community services. And you may say, well, how is this going to work? Again, I will reiterate, because I know that there are some professional bodies who are concerned about this, that this is not about delegating the management of contracts for primary care to CCGs. That will be a responsibility of the board, but the partnership between the board and the CCGs should put us in a position whereby CCGs are able to help with an understanding of primary care on the ground. But as CCGs, you will have considerable other levers at your disposal to work with primary care. For starters, the primary care practices are members of your organisation. Your organisation is them, it is just them. And I know from experience how much that will, through the use of peer pressure and sharing of information, start to drive up standards and quality in primary care. And that will be one of your main tools and levers. But you will have there will be other areas where primary care, the practices and CCGs working together will be able to use incentives and levers to drive up quality. The NHS Commissioning Board in the next few weeks will be producing the document which was once known as the planning guidance, but it will almost certainly not have that name because we want to move away from the top-down. I'm sure Ian will talk a bit more about this tomorrow. We want to move away from the top-down approach of planning guidance, but the board will be producing a document which is a kind of framework and basis for 2013-14. It will be identifying the CCG allocations and the range of areas based on the mandate, based on the broad outcomes of the mandate, which the NHS has to deliver, and CCG's role in delivering those outcomes. It should, we should expect as part of that to be able to give more detail of the quality premium, which of course will be key for you as in working with your practices. If you deliver the outcomes, you'll be able to have the quality premium to distribute. We've also said that all the local enhanced services money will be at the disposal of CCGs, so the board in future will absolutely only concentrate on those core elements of general practice which are delivered nationally and which have to be consistent nationally. For all other elements, it will be up to CCGs to choose what they do with not only the LES elements of budgets that they will get, but also their wider budgets in order to improve and enhance primary and community services. And in addition, and we hope to have more detail on this shortly, that CCGs will have responsibility for the locally delivered elements of IT. Which again will be something in which we hope that you will be able to use to drive improvements in quality and improvement performance. So I can't think of a more exciting time for us to be facing. I recognise that in the room there are some frustrations because we all want to get on with it and we're still in transition. And I would just ask one last thing of you is please be patient through the transition and don't judge people who are currently trying to do two jobs, one in the old system and one in the new system. CSUs, for example. We are really keen that CSUs, there will be CCGs servants. There's no other way. You have the money. If you don't like what CSU is selling, you will go somewhere else to buy the service. But we do want to see CSUs taking on board a lot of the transactional and the more managerial aspects to allow CCGs to remain light on their feet. But in CSUs and in PCT clusters, we have a lot of people who are moving forward into the new world with you and will be undertaking an enormous new role, but who actually have a massive responsibility over the next few weeks to actually make sure that the NHS is safe in their hands, because they still have the statutory responsibility over the next, and it is a few weeks, I think it's 90 working days about the maximum until we go live. So please, I know you're all excited, I know you want to get on with it, I know you're not like the people in Life of Pi in the cage who, when seeing the doors open, didn't get out. I know you're desperate to get out, and I think that great things are to come, and I would ask, my one last plea would be just that over this next few weeks, please have patience with those people who not only are going to be there to help us in the future, and some who aren't, who are going, but actually are absolutely critical to getting us through the next few weeks so that the NHS you inherit on the 1st of April to manage will be in the absolute best shape it can be. Thank you.